Good afternoon, everyone. I see you all are joining the Zoom right now. We might wait for a few minutes to let other participants join the Zoom, but I will go through the agenda for today's webinar first. So, good morning, good afternoon again. On behalf of the organizing team, I would like to warmly welcome you to the SIOP Asia educational session. And my name is Praploy Amonsilapachai, and I am pleased to help facilitate today's webinar. Today's topic is optimizing treatment in neuroblastoma and its application in low-middle income country context. We are honored to have distinguished speakers with us from across Asia. Before we begin, I would like to briefly review today's agenda and time allocations. For the opening remarks, it will be given by Dr. Tivorg, and then the keynote presentation. So first it will be the opening remarks by Dr. Tivorg, who is the president of SIOP Asia, for 3 minutes, and then we'll move on to the regional perspectives, which will be given by Professor Samat Pakakasama for 2 minutes, and then we'll move to countries highlight, which we'll cover from Thailand, Dr. Shalini Monserinoson for 8 minutes, and from Philippines, Dr. Pamela Fajado for 8 minutes. And then we'll end with keynote presentation from Professor Alice Yu for 30 minutes. And lastly, but not least, the Q&A and open discussion for 10 minutes. So we kindly ask all the speakers to keep it in their allotted time so that we can ensure room for the discussion at the end. If the time is running short, I will send a private message in the chat as a gentle reminder. With that, I think we can begin. So our first speaker is Dr. Tivorg, the president of SIOP Asia, who will deliver the opening remarks. Dr. Tivorg, the floor is yours.
Thank you very much, Prafloy. Hi everyone, and welcome to our educational sessions on the SIOP Asia. First of all, I would like to thank Dr. Shaline, my good friend, for making this happen, and her team, Praploy and the others. This is a new initiative doing these educational sessions through the SIOP Asia, and Dr. Shaline is kindly chairing this our initiative, and I'm sure it's going to be a great success. During these educational sessions, we will hear both distinguished speakers from the different subject area experts from different parts of the world, but as well as we will hear local experts from Asian countries representing the current situation in their countries, current situation of pediatric oncology in their countries. Again, thank you very much, and thanks also to all the speakers who agreed to deliver the presentations today. I think it's also great that we're starting this initiative in September, Gold September. Everyone knows this is September is the Childhood Cancer Awareness Month, and I'm sure with joint effort we'll move forward the development of pediatric oncology, not only in Asia, but also globally. Thank you very much.
Thank you very much, Dr. Tivorg, for the opening remarks. Our next speaker is Professor Samat Pakakasama. He is the chair of Thai Pediatric Oncology Group, who will give a short preface to the regional perspectives. Professor Samat, please.
Okay, can you share slide for me, please? First of all, good afternoon, all participants and speakers. So on the behalf of the Thai Pediatric Oncology Group, or Thai POG, it's my honor to welcome you to these educational sessions. So next slide, please. So allow me to briefly introduce Thai POG to those who may not yet be familiar with our work. Thai POG was established in the year 2000, and today we are proud to have grown into a strong network for 155 members and across 71 institutes throughout Thailand. Our primary aim has always been clear: is to improve the outcomes of Thai pediatric cancer patients. So we pursue this goal through several important activities. Developing standard treatment protocol and guidelines. And we provide educational courses and conference to strengthen knowledge and skill of pediatric oncologists. And we initiate and support multi-center research study that generate data for improving treatment and care in our local context. And importantly, we build strong collaboration with international pediatric oncology societies so that Thailand is always connected to global advances and best practice in pediatric cancer care. So during this session, I encourage everyone to actively participate, ask questions, and exchange ideas. Thank you once again for being here, and I wish you all a fruitful and inspiring sessions. Thank you.
Thank you very much, Professor Samad. We now move on to the country highlights, beginning with Thailand. It is my honor to introduce Dr. Shalini Monserinusorn, pediatric hematologist, oncologist from Thailand, and also the SIOP Asia ambassador. Dr. Shalini, the floor is yours. Sorry, your microphone is still muted.
Okay, so sorry for everyone. Good afternoon, everyone. First of all, I would like to thank the SIOP Asia, GWORK, and everyone for giving me an opportunity today to present. And today we will share our effort in Thailand in optimizing the neuroblastoma care, especially in the context of the limited resources setting like Thailand or low middle income country. So I will cover the four main domain area for today: the epidemiology of the neuroblastoma in Thailand and the overall situation of neuroblastoma right now in Southeast Asia, and how we can adapt the protocol for Thailand and the therapeutic strategy in the setting without access to immunotherapy. So the neuroblastoma is the most common extracranial malignant solid tumor in Thai children, with an incidence of 4.9 per million. A decade ago, our high-risk neuroblastoma had very poor outcome, less than the 30% of the survival rate due to the late presentation and the lack of resources. In 2016, we conduct a regional study involving the 17 centers from Southeast Asia countries. We found that over 50% of the neuroblastoma cases presented late. Surprisingly, the late presentation wasn't significant different among upper and the low middle income countries. Abandonment is a persistent issue, especially in the sarcomas and the neuroblastoma. Most centers lack legal protection for pediatric cancer care, and the patient tracking remains inconsistent. We applied the INRG and INSS system, and the Thai POC has adapted the risk group to match our capacity. Why the high-income country use the 11q aberration and DNA ploidy for risk stratification, but there are still diagnostic limitations like MIBG scan, mixed testing, DNA ploidy, and 11q testing are not universally available. So our protocol adapted the Chimahada histology instead. Challenging that we face are the diagnostic and the risk categorizing factors. The MIBG scan, the MIG testing, DNA ploidy, and 11q testing are not universally available. And from the oncologist perspective, the financial burden remains the top barriers. Other challenging issues include the travel difficulty, infection risks, and the fear from surgery or radiation, and the treatment abandonment. Fortunately, Our universal health coverage most of the basic treatment needs, including the surgery, chemotherapy. However, some advanced treatment like the stem cell transplantation, cis-retinoic acid, and the MIBG treatment are not covered. Previously, like 10 years ago, we treat the high-risk neuroblastoma with the cisplatin-based regimen, and the outcome was very poor, less than the 30% of the survival rate. Why the COG include the 6 cycle of topotecan-based induction therapy, followed by the local control and the consolidation with the high-dose autologous stem cell transplantation with stem cell rescue, and the maintenance with the cis-retinoic acid and the anti-GD2 with excellent outcome. However, due to the financial limitations, the Thai universal health coverage does not include stem cell transplantation and cis-retinoic acid and the immunotherapy. So this is the summary of the challenging issue for most of the country with limited resources like Thailand encounter. So in 2019, our team on the behalf of the Thai Pediatric Oncology Group study and report the benefit of using the topotecan as an induction regimen for Thai children with high-risk neuroblastoma as previously reported in the COG study. From this research, all Thai high-risk neuroblastoma patients received the topotecan-based induction regimen with the universal health coverage. So as a principal investigator, I and the Thai POC member subsequently studied the enhancing outcome in high-risk neuroblastoma by using autologous stem cell transplantation compared with the historical ICE regimen as a consolidation phase, and report that the outcome of this non-immunotherapy regimen in 2022 with the superior outcome from less than 30% to the 72%, stem cell transplantation was proposed as a standard treatment for all Thai high-risk neuroblastoma patients with the fully government coverage nowadays. In summarize, even in the low and middle income country, we can achieve the good outcome in high-risk neuroblastoma using the multimodal strategies. And while immunotherapy offers the further improvement, it must be evaluated carefully due to the cost and the toxicity. For now, autologous stem cell transplantation and the cis-retinoic acid maintenance represent an effective and practical standard in the resource-limited setting. Thank you very much, everyone, and please feel free to contact us or the Thai Pediatric Oncology Group if you would like to collaborate or to learn more for our situation. And again, thank you for the SIOP Asia for the wonderful opportunity.
Thank you so much, Dr. Shalini. We truly appreciate your insights. Let us now turn to Dr. Pamela Fajadu from the Philippines. Our final regional speaker, Dr. Pamela Fajadu, she is SIOP Asia Ambassador from the Philippines. Dr. Pamela, please go ahead and I will share your slides.
Thank you, Prilay. Okay. Welcome, everyone. Today, we'll explore how we can improve neuroblastoma treatment in resource-limited setting using PGH as an example. Neuroblastoma, as we all know, is the most common intracranial solid tumor in children and presents unique challenges in the Philippines. These are my objectives, which will guide our discussion, and by the end, you'll be able to link global standards with locally feasible actions and advocate for needed changes. Next slide, please. Okay. So neuroblastoma represents a significant pediatric oncology burden as it is the most common cause of extracranial solid tumor in children. It originates from the primordial neural crest, and its behavior ranges from spontaneous regression to aggressive metastatic spread. Risk stratification integrates clinical, biological, and genetic factors, with survival over 90% for low intermediate risk cases, but only 40 to 50% for high risk despite intensive therapy. The INRG classification is used worldwide. However, in low-income countries such as some markers may be unavailable, so clinical judgment often guides risk stratification. Neuroblastoma accounts for 7 to 10% of pediatric cancers globally and contributes to 12 to 15% of cancer-related deaths. Its incidence, 10.5 per million children aged 0 to 14, with slight male predominance of 1.2 is to 1. Neuroblastoma is the most common cancer diagnosed in infancy, with most patients diagnosed between 0 to 4 with a median age of 19 months. Although there are no significant geographic variations in incidence, there are ethnic disparities in outcome. Is it because of could this be attributed to genetic differences, such as the observation that African American and Native American patients more frequently exhibiting high-risk features and corresponding poorer outcomes? What about environmental factors, including parental exposures and socioeconomic factors, which includes health access? Early detection and risk stratification are often delayed in low-income countries due to limited access to healthcare and diagnostic services. Understanding epidemiology helps prioritize interventions. So the Philippines is an archipelago with a country made up of thousands of islands, around 7,641. It is divided in three main island groups. And the Philippines remain highly vulnerable to climate-related disasters, over 70% of the population at risk and limited access to basic public services such as water, sanitation, health, and agriculture. In a region where communicable diseases, neonatal deaths, malnutrition contribute the greatest burden to healthcare systems, the incidences of rare diseases such as neuroblastoma, even in the presence of these specific registers, are inaccurately recorded. The Philippine General Hospital, simply referred as UPPGH, is a tertiary state-owned hospital administered and operated by the University of the Philippines, Manila. It is designated as the national oh, it is designated um, as the National University Hospital and the National Government Referral System and had a bed capacity of around 2,200 beds. In our review of neuroblastoma cases from 20 to 2025, the median age of diagnosis was 2.5 years, with a male to female ratio of 1.7 is to 1. The most common presenting feature was abdominal mass in around 80% of cases, followed by fever, neurologic symptoms, respiratory findings, and weight loss. In the absence of molecular studies, laboratory markers such as LDH and median ferritin were noted to be elevated in our patients. 6 patients underwent surgery, but only one had complete excision of the mass. In terms of outcomes, only 3% remains alive, while 10 died and the rest had relapse, progression, or abandonment of treatment. The key point here is that most children presented with abdominal masses and systemic symptoms reflecting advanced disease at diagnosis, which correlates with the high mortality rate. Next slide. So what are the challenges in diagnosing neuroblastoma in our institution, or even in the Philippines as a whole? One is the limited awareness and delayed presentation. Parents and even some primary care providers may not recognize early neuroblastoma symptoms such as abdominal mass and bone pain, leading to late-stage presentation. Likewise, advanced imaging such as MRI, PET-CT scan, and MIBG scans, molecular tests, and pathology expertise are concentrated in a few urban tertiary centers. Many families also rely on out-of-pocket payments. Even with the PhilHealth coverage, some diagnostic procedures and targeted therapies are not fully reimbursed. There's also lack of standardized referral pathways, causes delay in transferring patients from provincial hospital to specialized pediatric oncology units. There is also absence of a comprehensive pediatric cancer registry which hampers planning and resource allocation. Delayed recognition, limited access to diagnostics, and financial barriers are key obstacles. Likewise, other challenge. So, what are the challenges in optimizing treatment? Stockouts or inconsistent access to essential chemotherapy drugs and limited supportive care such as antimicrobials, blood products in some regions. Surgical expertise is also an issue. Pediatric surgical oncology expert is not uniformly distributed, making complete resections difficult, especially in outside major centers. There is also limited number of functional linear accelerators and trained staff. Furthermore, immunotherapies such as anti-GD2 antibodies, stem cell transplant, and ALK inhibitors remain largely unavailable. And there's limited survivorship program to monitor the leg effects of therapy. So this figure contrasts the ideal stepwise care for high-risk neuroblastoma in high-income countries with the challenges we face at PGH. In wealthier settings, treatment flows smoothly. Induction, surgery, transplant, radiation therapy, targeted therapy, and relapse management. But in low and middle income countries, every step faces obstacles, late or misdiagnosis, limited access to tertiary care and imaging, scarce surgical and transplant services, drug shortages, and weak supportive care. These gaps leads to advanced disease at presentation, treatment toxicity, abandonment, and lower survival. Optimizing care at PGH means reinforcing each link, early detection, reliable chemo supply, referral pathways, supportive care, and partnership for specialized services. So what are the strategies in optimizing diagnosis and treatment? So the following are the proposed actions. One, launch nationwide education campaign for primary care providers and communities, and integrate pediatric cancer red flags into rural health unit protocols. Also, establish standardized region-based referral system with clear guidelines for suspected neuroblastoma cases. Use telemedicine for rapid consultation with tertiary hospitals. And increase regional access to MRI and MIBG scans via government-private partnership. Likewise, we may subsidize molecular testing through PhilHealth or charitable foundations. Also, implement national procurement strategies to prevent stockouts and ensure quality generics. It's also good that we should support regional pediatric oncology hubs with multidisciplinary team composed of oncologists, surgeons, radiologists, and nurses, and use risk-stratified evidence-based regimens tailored for low-middle income settings such as using the COG or the PGOG adapted protocols. And again, we encourage everyone to join global clinical trials or twinning programs such as the Global Neuroblastoma Network and SIOP, and create programs for late effects monitoring, psychosocial support, and palliative care integration. These strategies are realistic and may be and adaptable to PGH contexts. So in conclusion, neuroblastoma survival disparities persist in low-income countries, and PGH exemplifies both the challenges and opportunities for improvement. Early detection, consistent referral, and risk-adapted therapy are key, and strategic partnerships and advocacy can transform outcomes. So what's my take-home message for this? We should act early by community and primary care awareness to save lives, adopt smartly, use evidence-based resource-appropriate protocols, and collaborate broadly, partnership, local and global, to enhance capacity, and invest sustainably, doing policy advocacy and funding for long-term success. Despite resource limitations, PGH has the potential to model how low-income countries can optimize neuroblastoma care. With early detection, standardized protocol, and partnerships, we can close this survival gap. So these are my references. Thank you everyone involved in improving pediatric cancer care. Thank you.
Thank you so much, Dr. Camila Fajado. And I'm so sorry to inform you all that unfortunately, Professor Alice Yu, our keynote speaker for today, is unavailable, is unable to be with us today. We truly value her planned contribution, and we hope to circulate her materials or invite her in a future session. But for now, we will proceed to the Q&A session. So for the Q&A session, anyone who have the questions that you want to ask, either in general to all the speakers or to specific speakers, you can either raise your hand and speak, or you can write the message in the chat. So, okay, so I see there's one Q&A. Given the current data, what do you think about using upfront MIBG treatment and also adding an ALK inhibitor and DMFO in our setting?
So I will answer this question. So I think it's a tough question because as like in Thailand, we don't have, it's not universally available for the MIBG treatment, and also other like ALK inhibitor, and also the DMFO that is like maybe it's costly, and all most of the patient in Thailand. And I think in most of the low and middle income country have faced with the financial limitations. But currently, like our situation, if it's like, we can, cut off these factors, and I think the upfront MIBG treatment maybe is not that applicable in the Thai population yet, because as the host in Thai setting, also like the infection rate, and that as the upfront for the MIBG and all that we mentioned maybe is risky, and we think that the standard treatment may be optimizing enough. Yeah.
Thank you so much for your answer, Dr. Shalini. So we have our next question. How effective is immunotherapy for neuroblastoma?
Dr. Pamela, you would like to answer this question?
It's none. We don't have any local data. Most of our patients who had used immunotherapy were the ones accepted at the St. Jude. And I only know one, and she's still alive by this time. So what I think the most important factor, or what the one with good outcomes, are still the children who are less than 1 year old when they had their neuroblastoma.
Okay.
Yeah.
So it's like selected case, right? It's a selected case, right, Pamela?
Yes.
Okay. So as like in Thailand, and Thailand experience, we have a limited number for like the patient with immunotherapy, because as we face, I think the most challenging is because it's the supportive care for the immunotherapy. So we try from the limited case, if we comparing to the majority that not is a non-immunotherapy treatment, I think at my perspective, I think it's like, we can do with, just like autologous stem cell transplantation followed by the cis-retinoic acid and maintenance. I think it's okay. Even, if like, if the patient not like the MYC amplification, something like that. So if like the high risk that, have the mixed amplification, or have the refractoriness or something like that, maybe we try to consider the immunotherapy.
Thank you so much for the answer for this question. The next question is from Bangladesh. So it is asked that no stem cell transplantation facility is there in Bangladesh, and right now the facilities for MIBG scan as well with no molecular test. What should be a treatment strategy for the high-risk neuroblastoma patients?
So I will be the first one, and then let Pamela answer the question later on, because in Thailand we just have the stem cell. I mean, the stem cell transplantation right now is like proposing to be the standard treatment, and I think it's around like 20 to 30% of the patient, I mean like the newly diagnosed high risk neuroblastoma that receive the autologous stem cell transplantation. So I think we can use like consolidate with the ICE protocol. I think it's like the survival rate is the effectiveness is around like the event-free survival is around like 50 to 60%. I think it's okay. But however, the supportive care during the consolidation is mandatory. So we can do with the ICE regimen. And also the MIBG scan, if it's not available, I think we can substitute with the like just like technetium bone scan, and all like CAT scan and combined with the bone scan is enough. So how's the Philippine experience?
Yeah. For high-risk patients, okay, especially those with bone marrow involvement and they are more than 2 years old, we don't use high-dose chemotherapy like cisplatin-based, but what we give is the POG intermediate risk. So don't like, our main goal is to improve the quality of life of this patient, avoid, and with the infrastructures that we have, we want to avoid infection and what else? And because of the unavailability of blood products, we try to just simply improve the quality of life of these patients. Especially stem cell transplant is not readily available. It's only in the private hospital at this point. So access to the treatment is very difficult for our patients' family.
Thank you so much for the answer. Moving on to the next question. This question is from Maria Gutu. She's from Romania, Bucharest. Do you test all patients for ALK? And if it's positive, do you use ALK target treatment? If yes, how do you use it in parallel with other treatments? And she also said that thank you very much for the presentation and great presentation.
Thank you, Maria. For Thailand, we use the ALK targeted therapy only for the refractory cases. Because in Thailand we use like upfront with the consolidate with stem cell, either stem cell or like the ICE regimen. If the patient had received the ICE regimen before, if it's refractory, we will do like the autologous stem cell transplantation first, and then the ALK we can taste interim, and if it refractory again, maybe we consider the ALK, but it's like the financial limitation, and also the taste is not universally, like it's not a government coverage, so we will consider in the selected case. But we have some cases that use the ALK inhibitor in the case with the ALK positive.
Okay. The next question. Thank you so much for the great talk. Would you please shed light on some global collaboration and training opportunities, like some global working groups specific for neuroblastoma, and how to join them?
Pamela?
Yes.
Yeah, like
Yeah.
you
Yeah,
could-
we have been participating in Global Neuroblastoma Network since 2010. Yeah.
Mhm.
Yeah. And we
like
presented cases, and they help us, especially regarding management of these cases, particularly surgical planning.
So we encourage everyone to join the Global Neuroblastoma Network. We had, the meeting on the every Thursday night, like the tropical time, our time. So yeah, and we can invite you to join.
So we've got some the global working groups for neuroblastoma for you to join if you are interested. So the next question, what needs to be done to establish a unified center for affordable standard early diagnosis and treatment modalities in our region? Is this a possibility, or is it just a dream?
It's an interesting question. So I think in Thailand, the number of the treatment abandonment of the neuroblastoma is decreasing, like over time, and I think we don't need to use like unified center. I think what we can we can educate the pediatric oncologists across the country, and the need and educate the patient, the pediatric patients and family as well, according to the early signs for the neuroblastoma. I think maybe it's easier to unify the center. What do you think, Pamela?
Okay. I believe in shared care. I think that's the key to success if you want to improve the care for patients with neuroblastoma or even other cancers in children. Because sometimes it's very difficult to uproot the family from their place because it's high risk for abandonment. So, for example, if the surgical procedures or radiation therapy are not available in that area, and especially in the provinces, they can refer to us in Philippine General Hospital for these cases. We have started this already with hepatoblastoma. So most likely this can be followed by neuroblastoma.
Okay, that was indeed a very interesting question. The next one, thank you for the wonderful sharing. In Indonesia specifically, the condition is quite similar, but we don't have access to topotecan. In this situation, what protocol would you recommend as the first line? Currently, we are still using cisplatin base. Yes. So
And,
yes, that's the question.
and also like the European protocol. I think we can use that one, the cisplatin bed, because you know in Thailand previously we used the cisplatin base, and the outcome, I think the outcome may be that one is a little bit not that good because of the, you know, it's a lot of factors like supportive care. But however, if we can combine the good supportive care with the cisplatin, I think it's gonna be promising. I think it's okay with the cisplatin. Pamela, what the situation in the Philippines? You use the cisplatin as well, right?
Yeah. We use mostly carboplatin for these cases. We're following the intermediate risk set by POG, you know, in which the patient able to tolerate. But of course, the outcome is not, especially for high risk patients, because why proceed with something, you know, with cause a lot of toxicity, but in the end, it will not improve the life of the patient. I think that's the goal, especially if you'll not be able to augment the other treatments. Would you consider,
Okay.
would you do the same?
Yeah, we previously we do with the carbo and all, and we use the cisplatin base, but some protocol individualized with the carboplatin as well. But right now we move to the topotecan because it's like universal coverage. I mean, like the government coverage, the full funded. I think the cisplatin is not superior. It's not. I mean, comparing to the topotecan, I think the challenging one is a side effect. You know, with the like electrolyte imbalance and something like that. Yeah.
Yeah.
Thank you so much for your answers. The next question is there any special considerations for 17 years old patient following the same treatment in high risk protocol as the pediatric patients?
I think the 17 years old, we can use the pediatric protocol because in Thailand, we also treated the patient as the adult, adolescents and young adult with the children protocol as well. So we cut like the age around 18 years old. So I think we can use the same one. But the special consideration, I think, is a side effect. Like, you know, like the older patient could have the more side effect.
So move on to the next question. What is the optimal strategy for disease surveillance following completion of the treatment?
Okay, in our setting, we have more access for PET CT scan at the point. Actually, rather than MIBG scan, because it takes around 4 weeks before we can get the dye for MIBG scan, and so we monitor using the PET CT scan for these cases. And the rest of other examinations, of course, depending on what chemotherapeutic agents we did give.
So in Thailand, in Thailand we also use the PET CT, but if it MIBG positive, we can also the surveillance with the MIBG as well. But you know, the duration and the frequency, we follow the COG protocol. However, in the limited resources, we can extend it, like, you know, not every like 3 months. Maybe it's like every like twice a year or like quarterly, something like that. We can adjust. And we can monitor with the, like the marker, with the serum marker, like NSC, something like that, maybe easier if it is high at the presentation.
Thank you so much for the strategy. And we have the question about would you mind sharing your experience on chemotherapeutic regimens of choice for patients with residual disease after local control as bridging for bone marrow transplant?
So for Thailand, we use the topotecan as the induction regimen. Like the first 2 cycles with the topotecan. We use that one interim, like at the bridging, and with the MIBG treatment. How about in the Philippines?
Before I was able to use topotecan, but these are not available anymore in the Philippines, the IV preparation. And really, it's very easy to use and easier to use and less toxicity on my patients. But now, you have to, the other option would be using ICE protocol, ifosfamide, carboplatin, and etoposide. And let's see how, and then radiation therapy for the rest of the cases.
Next, we still have a lot of questions coming. How can we improve the survival rate of the ALK positive neuroblastoma in our region?
So for us in Thailand, we don't have much data of the ALK positive neuroblastoma. So we use the ALK, as I mentioned, that we use only for the refractory cases. So we improve, when it's like refractory, sometimes we can achieve the remission for maybe like 6 months, a year. And then I had like, like 1 or 2 cases, and it's relapse again. So it's improved, it's not, we can extend the survival a little bit.
Shalini, I have a question. Do you do a frontal inhibitor testing for your newly diagnosed neuroblastoma?
No, we don't do that like routinely. We just do it, it's like relapse.
And during relapse, okay. Thank you.
Okay, so there's this question for the invitation to join the Neuroblastoma Global Network. How actually could the interested join? Like, do we need like the participant email or the invitation link?
Pamela, do you have any access to the GNB?
Global. With what?
The Global Neuroblastoma Network.
The Global Neuroblastoma Network through St. Jude, Care for Kids, right?
Oh, yes. Yeah. You can join by the.
Yeah, you have to join the group for be able to access the platform.
Okay.
Okay. Just for clarification, how to join the group, like through the website?
So I think we can I think everyone will have access to the Cure for Kids. So for the St. Jude Global, and you can find the Global Neuroblastoma Network, and then you can access that. Yeah.
Okay. The next question, how may we improve drug accessibility on a uniform basis to all the countries in our region?
Pamela? Yeah.
What was the question again? Sorry. How can unified? Can you repeat the question?
Yes. So the question is, how may we improve drug accessibility on a uniform basis to all the countries in our region?
Drug accessibility. Yeah, probably one is by pulling the or by pulling the needs for some medications, not to for us not to wait to one to prevent wastage of medicines. Number two, we have to lobby for these medicines. And the problem also lies with the drug companies who are making this systemic chemotherapy because everyone, some pharmaceutical company are into targeted therapy, right? We have to really lobby from these manufacturers to continue this type, making these medicines available, especially for those who are cannot still use the immunotherapy.
Thank you so much. So this is our last set of questions due to the time limitation. Okay, so the next question, for the high risk, what do you use as induction chemotherapy protocol in your institution?
So in Thailand, we use the topotecan-based induction regimen. And the Philippines uses carboplatin, right?
Yes, POG 965. Carboplatin, doxorubicin, etoposide, cyclophosphamide for these cases.
Thank you so much. The next question is from the head of pediatric surgery. I'm not sure if I would be pronouncing your name correctly. From Shanur Islam, from the hospital in Bangladesh. So he or she mentioned that there is no center of excellence in the hospital. For this reason, we try to work collaboratively with different hospitals where facilities are available at this moment. Is this strategy correct or is it appropriate in your views right now?
Yeah, actually, there's a Southeast Asian meeting, also sponsored by Viva and St. Jude every Thursday. I think second or third Thursday of the month. And we even invite our pediatric surgeon to participate in this meeting so that they can raise their questions. They can also be taught on the surgical planning for these cases.
Okay.
Yeah.
The next question, I believe, is from the preceding question with a patient of 17-year-old. So that question is that, is there any special considerations for a 17 years old patient following the same treatment and high risk protocol? For this question specifically, we have more information regarding the patient receiving Bumel over CEM. Is there any side effects or any special considerations?
So I think the special consideration, we usually use the Bumel over than like rather than the CM. So I think, but I think the side effect is not that different in terms of the aging. I mean, in terms of the age group for me, but we need to consider like, if the patient's like obese, because 17 is made like adult. So we not exist like, like the BSA over 2. So this is my consideration.
Okay, thank you so much for the answer. And here is our last question for today's webinar. In Bangladesh, we have no MIBG and MIG application. For this reason, we use serum LDH, ferritin, 24-hour urinary VMA in follow-up or prognostic factor. Is there any other options recommended?
For monitoring, as I have said earlier, aside from those tests, except for the urine VMA, because if it's negative at the start, and most of our patients, more than 50%, will always have a negative urine VMA test. So what we use for monitoring, aside from the LDH, ferritin, even CBC, syempre, basically you do your physical examination, history and physical examination. And then we also use PET CT scan for these cases.
So I think it's like if we consider like other prognostic factor other than the NMIC amplification or like MIBG for the metastatic evaluation, I think we can, maybe sometime we can use like other factors like the age group, if like older than like 4 years old with like high LDH, with high ferritins and high serum NAC or like high serum high urine VMA, we can do, we can consider like as a high risk, even it's not NMIC in no NMIC amplification testing. So we can consider other factors according to the COG or like, like INSS or like INRG stratifications. So we can use that one.
Thank you so much for all the answers. So now, as we come to the end of today's session, I would like to again sincerely thank our distinguished speakers, Dr. Jivork Tamamyan, Professor Samat Pakakasama, Dr. Shalini Monserino-Son, and Dr. Pamela Fajado for sharing their expertise. We also extend our sincere thanks to all participants for your active engagement. The discussion has been very lively with over around 20 thoughtful questions, which truly reflects the importance of this topic. Unfortunately, Professor Liz Yu was unable to join us for today's session. We deeply appreciate her planned contribution and hope to welcome her in a future SIOP Asia education session. On behalf of the organizing team, we are grateful for your participation, and we look forward to seeing you again in upcoming SIOP Asia activities, which for the upcoming session, it's planned to be hosted in this December. So there will be more information regarding this. With that, we officially close today's webinar, and we wish you all the wonderful day. Thank you so much.
Thank you.
Thank you.